Good evening, everyone. This is Alan Ho, and I am Professor of Ophthalmology at Thomas Jefferson University and the Director of Retina Research at Wills Eye Hospital. Tonight's webinar, sponsored by Iridex, is on MicroPulse laser therapy and the management of diabetic macular edema. And I'd first like to thank you for being here with us tonight and introduce my co-panelists. First, Dr. Robert Avery, founder of the California Retina Consultants and a very experienced retina specialist. Dr. Larry Morse, who's in academic medicine in the retina department at the University of California, Davis in Sacramento. And Dr. Elias Reichel, director of the Vitreoretinal Service at Tufts New England Eye Center, all of whom have had significant experience with MicroPulse laser therapy and the management of diabetic macular edema. First, some initial thoughts about MicroPulse therapy, laser therapy, in this era of injections, anti-VEGF injections, and other injections in clinical trials for diabetic macular edema. I think the purpose of this webinar is to understand new laser technology and the existing evidence for MicroPulse laser in the treatment of macular diseases, not only diabetic macular edema, but other potential macular conditions associated with edema and fluid, such as chronic central serous retinopathy or retinal vein occlusion-associated macular edema. Even in this era of anti-VEGF injections, we all understand that there remains a significant unmet need in the treatment of diabetic macular edema, and a major take-home message from my standpoint is that the laser is still relevant for this condition, and we'd like you to consider the potential benefits of MicroPulse laser. By way of disclosures, and each of the speakers will give their disclosures, I serve as a consultant to Iridex and other companies that are involved with therapies for diabetic macular edema, including Allergan, Genentech, and Regeneron. It's useful to consider the history of laser and the evolution of treatment protocols, evolution implying that laser yesterday is not the same as laser today. And we know that from a hardware standpoint, and that is laser starting as large water-cooled tube-based energy sources for delivery of energy to the eye, to now current smaller box, tabletop boxes, solid-state semiconductor laser photocoagulators for ophthalmology that are produced by a variety of manufacturers. And it's something that we now enjoy, and certainly reflective of the ease of obtaining and using hardware, a more compact solid-state delivery system. If you look on the right-hand side of this slide, it also depicts an evolution and change over time. The first box at the top, the box of 4, shows a traditional thermal laser burn pattern with a white central intense laser treatment. This is high intensity, and low density refers to the number of laser treatment spots in an area with respect to the area that is untreated. Take particular notice, however, of the little speckling surrounding the thermal laser burn. The thermal laser burn is something that is high energy, the energy absorbed in the macula by relevant pigment tissues such as the retinal pigment epithelium and the choroid, with overlying protein and tissue destruction, thermal damage, protein coagulation of photoreceptors all the way up to the internal limiting membrane of the macula as we observe a laser burn clinically in practice. Laser burns then were modified in terms of intensity, and you can see that the next box shows lower intensity laser burns which have less of a thermal full thickness effect, still visible when you do the treatment, and also some surrounding speckling implying laser tissue effects, but no overlying destruction of tissue. In the third box, you see what is known and what we'll speak on, which is MicroPulse laser therapy, which is low-intensity laser burn, essentially capturing that tissue response, the speckling, from the laser energy that's delivered. And you see this in a low-density pattern. In other words, there's quite a bit of untreated macular tissue compared to treated macular tissue. And finally, you'll see the concept of MicroPulse or low-intensity, again, speckled pattern, non-protein coagulating, non-thermal damage, with tissue stimulation in a high-density pattern. And this is what we'll be speaking to, and our speakers will be talking about today as an evolution of a laser treatment protocol. To summarize some initial thoughts, and MicroPulse laser is non-invasive. You can decide based on the evidence provided by Doctors Avery, Reichel, and Morse whether it's safe or not. I submit that it's an underutilized tool, not only for diabetic macular edema, but for other macular conditions with leakage and edema. There is an increasing evidence base, quality evidence base for the safety and efficacy of MicroPulse laser, and our speakers will be talking about studies, Dr. Reichel in particular. And finally, as you consider incorporating this into your practice in this era of injections, you need to be prepared to be patient in terms of tissue response. Patient, that is, the response or reduction in edema doesn't happen very quickly, but takes time. At this point, I'd like to turn the program over to Dr. Larry Morse, who's going to talk about MicroPulse laser therapy and how it works, speaking on the energy profile of this type of laser technology and tissue response differences between thermal laser and MicroPulse laser. Larry?
Thanks, Alan. Today I'm going to further take you into a discussion of what MicroPulse laser actually is and how it's actually delivered. I do have some financial disclosures that are listed here. The first anti-VEGF treatment that we experienced in ophthalmology that really made a difference in our clinical practices was, in fact, thermal laser photocoagulation. And in that delivery of thermal laser photocoagulation, we were able to control both power and time, but there was a continuous on switch where the laser was on 100% of the duration of time that we actually selected. And our visible endpoints were a tissue reaction that we were able to directly observe, which controlled how we adjusted both the power and the time to satisfy whatever biological clinical effect we wanted to achieve. MicroPulse laser differs in that context in that it uses both power and time, but it divides that power into little pulses, little pulse trains, which don't allow thermal buildup, and accordingly, there is just a mild elevation of temperature that occurs in that biological setting, and then a complete relaxation of that energy so that the biological thermal endpoint of actually seeing a lesion is actually lost. And this is an example showing a 5% duty cycle with the same time as the continuous wave that you just saw on the left illustrates, but that the pulse train of which no visible burns would be actually seen during this particular cycle. Now, we did a study at UC Davis where we used both green wavelength and red wavelength MicroPulse lasers and delivered energy to the retinas of rabbits. And in that study, we compared both wavelengths, and the first top left slide shows a threshold burn, which was just barely visible, just enough to give a tissue reaction in the animals. We were then able to turn the laser down to different duty cycles and then look at the histologic effect in a number of harvested rabbit eyes. And one example is like at the 40% duty cycle, that would be what was classically called a subthreshold burn. Well, we could not visibly see these burns, but as you can see histologically, there is thermal damage that destroys not only the retinal pigment epithelium, but also the overlying photoreceptors and even part of the inner retina. Now, this burn was initially not visible, but within 4 weeks, you could see evidence, both clinically, you could see evidence that there was a visible burn in the retinas of these rabbits. That was less evident at 20% duty cycle, and even at the 10% duty cycle, we were able to see RPE damage. And at 5% duty cycle, very hard to find any histological effects on the rabbit retinas. How does a laser actually work? And that's been intensely debated, but clearly with the it's clearly evident with continuous wave lasers that there is a thermal necrosis that actually happens in the center of each of those burns, which can be controlled by both the power and the duration that you give those burns. So how does a continuous wave laser work? Well, it works by destroying tissue. For example, you can destroy a microaneurysm directly, but then there's a sublethal rim, almost like throwing a rock in a pond where you get a ripple out effect. And in that ripple out effect, that tissue is not thermally damaged critically, but it does have a biological stress response that is able to also contribute to the enhancement of biological factors that may also be effective outside of destroying tissue directly. What distinguishes the continuous wave lasers from the micropulse lasers is that we do the laser in a totally different pattern. The laser is given in a low intensity but high density pattern where it's a confluent area that's actually treated, usually amounting to somewhere between 150 to 250 spots that you might actually place in a confluent pattern. And no thermal necrosis is actually happening within that particular region. And so you have a large area of biological stress to a cell that actually receives the laser treatment that can create a biological effect. And so how does one transcend from this period where we saw visible burns into a period now where we're seeing nothing? If you look at thermal laser, which, as we just mentioned, causes a point of tissue damage, we can actually find a lot of biological chemokines and biological markers that are anti-VEGF in nature. Both pigment epithelial-derived growth factor, thrombospondin 1, are clearly anti-VEGF and anti-angiogenic in their activity. Stromal cell-derived factor 1 actually recruits hematopoietic stem cells, which are probably reparative in nature. And we saw this not only in thermal treated laser eyes, and a variety of other labs have also demonstrated this, but if you look at micropulse laser, they have the same group of factors that are also modulated in this activity. Now, the first three that you're seeing at the top were diffusely expressed, whereas beta-actin was localized just to the burn itself, and that's a kind of a constitutive protein that does have roles in cell motility and integrity and structural effects, and it's more or less a control factor. But there is, even though the burns are, you can't see them, there is a biological effect from the stress from the laser treatment. So at this point, I would like to turn the podium over to Dr. Reichel, who will talk about some clinical studies now supporting the safety and efficacy of micropulse laser.
Thank you, Larry. My name is Elias Reichel, and I'm professor and vice chair at Tufts University School of Medicine, New England Eye Center in Boston. And I'm going to be talking about clinical studies that support the safety and efficacy of micropulse laser therapy for diabetic macular edema. My relevant financial disclosures include I'm a consultant for Iridex, I have royalties related to ocular instruments, and I am a consultant for Regeneron as well. The studies that I'm going to be talking about are important in that they outline the use of the different wavelengths that are used in micropulse therapy using the Iridex system. This includes the infrared 810 nanometer wavelength, as well as the 577 yellow wavelength. And parameters differ according to these wavelengths. That's an important concept to remember. We're going to also be talking about conventional laser, and it's used for primarily non-foveal treatments. However, micropulse laser can be used to treat the fovea, and that's an important concept as well. And finally, we'll be going over cases, and we'll be talking about the parameters that are very useful in using the micropulse laser for subthreshold laser treatment for diabetic macular edema. So the nice thing about micropulse is that you get clinical efficacy without damage, and the results of reduction in intraretinal fluid in treating diabetic eyes is comparable to the modified grid focal laser therapy that was promoted by the ETDRS studies. What's important to remember about micropulse is that typically there's no or limited tissue damage seen at any time point postoperatively. And in the studies that have been done by Vijosevic, it is apparent that there's significant improvement in retinal sensitivity with micropulse therapy, which is not observed in conventional laser photocoagulation using a modified grid or focal therapy. Clinical results with micropulsing for diabetic macular edema suggest that high-density spots are important in the treatment, which means that you have to have confluent or near-confluent therapy of the macula to treat diabetic macular edema. If you use micropulse with a high density, you can see approximately, on average, 150 micron reduction in retinal thickness and an improvement as high as 12 letters on the ETDRS chart. If you compare that to low-density micropulse therapy, you're only seeing a minimal change of about 30 microns, which is really not significant. What's important to remember is that the micropulse high-density therapy is comparable to the modified ETDRS therapy that was defined before the subthreshold era of laser photocoagulation. Luttrell has shown very elegantly micropulse clinical results in varying the duty cycle of the laser. And this is very important. It's very important to know that we see excellent safety at 5% duty cycle when compared to duty cycles of 10 to 15%. And in these studies, if the duty cycle is higher at 10 to 15%, 1 out of 12 patients will actually show evidence of laser-induced retinal damage, whereas at the conventional 5% duty cycle, which is what is now used, no patients showed any evidence of laser-induced retinal damage. So this is very important, and this data was supported by imaging of the retina of many modalities, which included red-free photos, fundus autofluorescence, fluorescein angiography, and ICG angiography, as well as spectral domain OCT. What's also important is that there are different wavelengths that micropulse laser photocoagulation can be done, and this includes 810 nanometer and 577 nanometer. And you can see 810 is that pinkish color, and 577 is yellow. And as far as the parameters are concerned, the spot sizes are almost equivalent, but if you're using infrared laser, you actually have to go to a higher power. And if you're using 577, you're actually using lower powers, something less than 400 milliwatts. In the study that was done by Vijosevic, their power setting was 250 milliwatts. The duration of the application is the same. It's 200 milliseconds. And the duty cycle, again, this is very important. Duty cycle remains 5%, regardless of what wavelength you're using. It's important to know that there are similar results with these different wavelengths, and that if you look at retinal sensitivity, there really is no significant difference in the retinal sensitivity based upon whatever wavelength you used. Whether it was red or yellow, there was increases in retinal sensitivity, and they were not statistically different. It's important to remember that laser still plays a very important role in the treatment of diabetic macular edema. And in Protocol I, patients who received deferred laser at 6 months did best compared to those patients in the study who received prompt laser. And you can see here that the blue line shows the best results with an average improvement of about 10 letters over 2 years in those patients who received anti-VEGF with ranibizumab and also received deferred laser at 6 months. Now, Protocol T also shows the importance of laser treatment. Now, these patients were treated with conventional laser, and if they had an incomplete focal grid laser therapy or no focal grid therapy in the past, they could receive laser at 6 months. And the criteria that were necessary for them to receive laser was a central retinal thickness that showed that there was edema threatening the fovea. They had to have at least 2 anti-VEGFs in a row. If there was a less than a 10% decrease in the central foveal thickness on OCT, and if there's less than a 5-letter visual acuity improvement, those patients would be eligible for receiving laser at 6 months in the study. So what's important to remember is that approximately a third to a half of patients, regardless of what their therapy was, received laser photocoagulation. Those who received bevacizumab required the most laser. Those who received aflibercept required the least number of lasers, but still a high percentage of patients required laser in Protocol T. Therefore, laser is still an important therapy in treating diabetic macular edema. The Texel-guided MicroPulse laser system applies confluent high-density applications of the laser to the macula, and you can see that in this video here. What's nice is the grid allows for visualization at the perimeter of the targeted area, and you get very consistent laser delivery. As you can see, there's increased efficiency, and it's versatile in that you can apply it both for anterior segment and posterior segment applications. So some practical tips for MicroPulse laser therapy is it's important to choose the right preset. So on the laser, you'll have choices where you can do micropulsing, you can do PRP, you can do conventional laser photocoagulation for retinal tears and holes. It's very important that you pick the right preset for MicroPulse laser therapy. Confirm that that mode is on. Confirm that you're using a 5% duty cycle. Make sure that the audio is enabled when using the wireless foot switch so that you know that you can get the output to determine what the power setting is while you're doing the treatment. It's important to place confluent high-density applications, just as was discussed earlier in the talk. And think about hundreds of spots, not tens of spots. And certainly be aware of landmarks. So you're not going to see any laser changes in the retina. So pick a landmark and stick with that landmark. Usually I pick a corner of the grid and pick a site on the retina where the top right-hand corner is going to lie so that you know exactly where you're treating. This is the first case. This is a patient with 20/60 vision who received MicroPulse monotherapy, and you can see central retinal thickness of about 530 microns with intraretinal fluid. This patient was treated with 577 nanometer, that's the yellow MicroPulse laser, 200 micron spot size with the constant 200 milliseconds duration. The power was 300 milliwatts and, of course, a 5% duty cycle. The grid was a 7x7, which was confluent with no spacing, 0 spacing. And this is the post-op 2 months later. Vision improved to 20/40. You can see that the retinal thickness is reduced by about 100 microns, and a lot of the intraretinal fluid has resolved. The next case shows a patient who had 20/40 vision. You can see that there's intraretinal fluid, and this patient received MicroPulse laser with 577 nanometers again, the standard 200 micron spot, 200 millisecond duration. The power was 330 milliwatts, 5% duty cycle, and again, a 7x7 grid without any spacing, 0 spacing. And you can see over the course of 10 months with one treatment, the patient improved to 20/25, and the intraretinal edema has largely resolved. Case 3 is another patient with 20/50 vision. You can see that there's not much on the color photograph, but there is some leakage related to the microaneurysms. There's central edema on the horizontal line scan of this OCT. And this patient was treated with 400 milliwatt power 200 micron spot size, 200 milliseconds, and received 161 spots that were confluent and in a 7x7 grid. You can see here that at month 4, there's not much of a change. And so this patient actually needed to be retreated. And at month 8, the vision was 20/50 with, again, that persistent area of central retinal fluid. The patient was again treated with 400 milliwatts, but received 343 spots using the 7x7 pattern. Patient returned at month 12, and you can see the vision has improved to 20/30, and the fovea looks almost normal here. So that's a quite remarkable result. But from this case, you can see that it's important to be, 1, persistent, and 2, that it's important to treat large areas of the retina with more spots than you would ordinarily do for, say, your conventional focal grid for diabetic macular edema. This patient would continue to be followed, and you can see that maintains excellent vision with almost normal appearance to the central macula. So thank you very much, and Larry's going to continue with his second talk.
Thanks, Elias. I'd like to share with you some clinical evidence that MicroPulse laser therapy can be combined with anti-VEGF therapy in the treatment of diabetic macular edema. Our objective was to determine both the anatomic and functional outcomes using a combination of MicroPulse laser combined with anti-VEGF injections in the treatment of diabetic macular edema. The rationale for this was that if you combine MicroPulse laser with anti-VEGF injections, we felt that there might be a synergistic effect that would lead to a decrease in the treatment burden of anti-VEGF injections. So we did a retrospective chart review at our institution where patients were looked at that had subfoveal diabetic macular edema and a history of MicroPulse laser and/or anti-VEGF injections. All of these patients, so patients were excluded if they had had previous focal laser photocoagulation, a history of any steroid injection, or any other retinal disease that would complicate the interpretation of these. So in essence, these were treatment-naive patients. So we found a small number of patients, 14 patients were identified, 7 in group 1, which received both MicroPulse laser and anti-VEGF injections using Lucentis with the 0.3 milligram dose. And the second group were matched patients that just received anti-VEGF injections only. So all the records were reviewed and a statistical analysis were performed. So in group 1, the group that got MicroPulse laser and anti-VEGF injections, all type 2 patients, they had both stages of proliferative diabetic retinopathy and non-proliferative diabetic retinopathy that were represented in this group. And the same demographics were evident in the group 2 patients, which were also all type 2 diabetic patients with either proliferative or non-proliferative diabetic retinopathy and that had diabetic macular edema. The groups were fairly well matched. The average age of group 1 was 66 years with a duration of 9 to 30 months of follow-up, with an average follow-up period of 13.7 months. And hemoglobin A1Cs were 7.3 in that group. Group 2, where they received anti-VEGF injections only, had an average age of 64 years of age, a duration of follow-up between 10 to 32 months, an average of 17.1 months, and a hemoglobin A1C of 7.8. So these were fairly well-matched groups. We used the Iridex yellow MicroPulse laser with a duty cycle of 5%. Spot size were all 200 in this group. Power was 400 milliwatts. Duration was 200 milliseconds. And we gave a confluent pattern that treated the macular foveal area involving the diabetic macular edema. In general, patients got between 150 to 250 laser spots in each setting. When we did this study, 4 of the patients had MicroPulse lasers at the initial visit, followed by anti-VEGF injections as needed, and they were followed monthly. And 3 of the 7 patients had 1 to 2 anti-VEGF injections with Lucentis prior to the MicroPulse injection, and they were given because we felt that patients had fairly thick maculas and that there was evidence circulating around for a couple years during this period of time that MicroPulse laser might be more effective in patients that had less than 400 microns of retinal thickness. So we would pre-treat them with 1 or 2 injections and then follow them for the duration of the study. What we essentially found was that in the group 2 that received anti-VEGF injections only, that roughly they received over the course of a year approximately 9 injections during that time period, whereas the group 1 patients that had a combination of MicroPulse injections with or MicroPulse lasers and anti-VEGF injections received on average of 4 injections. That's approximately a 60% reduction in the treatment burden, which was statistically significant. Anatomically, there was really no major difference that we found in terms of final visual outcomes. They all achieved good resolution of this intraretinal fluid, and they all had a fairly good vision at the final outcome. If you look at the retinal thickness, once again, they were all fairly similar with no statistical difference at the end point, which would be shown in the orange color there between the 2 groups. This is an example of what we would start with. This is an example of a patient that initially received MicroPulse laser followed by anti-VEGF injections, and the best corrected visual acuity was 20/50 at the initial presentation, and 14 months later, this patient had received 4 injections of Lucentis in addition to the MicroPulse laser, and at a visual acuity of 20/25. So we would conclude that this preliminary study showed a major difference in the treatment burden in the group that received a combination of MicroPulse laser with anti-VEGF injections. There was no significant difference in both the anatomical and functional outcomes between the 2 groups, and that combination therapy using both MicroPulse laser and anti-VEGF injections may in fact reduce the treatment burden in these patients with subfoveal diabetic macular edema. Now, this is a pilot study, and a formal, more prospective study is being organized and will start shortly. So at this point, I'd like to turn the podium over to Bob Avery, who will be talking about incorporating MicroPulse laser into your practice, considerations and expectations that he's noted in his practice group. Thank you.
Thank you, Larry. I'd like to talk about incorporating MicroPulse into your clinical practice and what to expect when you do it. These are my financial disclosures. I work for most of the anti-VEGF makers and some of the laser companies as well. Well, when you start using this treatment, the most important thing I think is that it's really a safe treatment. We've shown histologically that this is not causing damage, it's repeatable, the patients tolerate it well, and it's just something that has an unheralded amount of safety to it relative to other treatments. It's also more recently been shown to be clinically efficacious with randomized trials and a fair amount of clinical experience. It's a very easy treatment to do in the clinic, in the lane. It's rapid, any discomfort with it in the vast majority of cases. And it reduces the cost for many patients as it eliminates what's become the standard of therapy, agents which are sometimes fairly expensive for treatment of DME. It also has a benefit of being useful, the machine being useful not only for MicroPulse, but also for continuous ways to treat retinal breaks and even have an indirect with it. So it's somewhat versatile. I think one of the go-to treatments for this therapy is for diabetic macular edema, which doesn't involve the fovea, and we'll talk about that in a minute. It's a very good place to start with the treatment. And so this can also be used, as you've recently seen, as an adjunctive therapy to pharmacotherapy. And in addition to the treatment of DME, which I'm going to discuss, there are other indications such as central serous and vein occlusion and others that may have a potential role. So again, this is the machine itself, and as I said, it's fairly versatile. It can be used for continuous wave treatment for other diseases such as retinal breaks and panretinal photocoagulation, as well as glaucoma indications. So let's look at a few examples. I think it's a good idea to first use this laser treatment in patients with extrafoveal edema to convince yourself that it's really working. This patient is a 68-year-old man with diabetes who had extrafoveal edema when I first saw him. He had a history of a previous anti-VEGF injection which did not go well for him in another office, and he was very resistant to having another injection. He didn't really need it at this point anyway, but I'll show you his progression. Here he is a few months later, and you can see the edema temporally starting to encroach upon the central retina. At this point, I offered him the MicroPulse laser treatment, which was administered with no discomfort whatsoever. Here you see a few months later, the edema has reduced, as shown by the decrease in the red zone in the plot map. And it continued to stay away for several more months until it recurred about a year later with a much more significant area of edema centrally with large cystic changes. At this point, we went ahead and gave him another treatment of MicroPulse laser centrally. And here, 3 months later, you can see a reduction in the cystic changes centrally in his macular edema. There was some improvement in his vision as well. And we went ahead and retreated him at this point. That's one advantage of MicroPulse laser, is you can safely give it in a repeated fashion, even in the central macular region, without causing central damage that we're aware of. There was continued improvement, not only in the vision, but also in the central thickness of the retina. And he deferred treatment at this point, even though he had some residual edema still present, and he continued to further improve with further observation. And here, now, more than a year out, you can see almost complete resolution of the red zone in the plot map with continued further improvement in his central thickness and his visual acuity. Then 15 months after his previous treatment, he started to recur, but not enough to bother him, and then he was lost to follow-up. Here's another example of using MicroPulse laser as an adjunctive treatment to anti-VEGF therapy. This case, compliments of Dr. Mansour, shows that a patient who had had previous anti-VEGF injections but with still persistent edema, seen on the top of the slide, with some cystic changes and subretinal fluid, which resolved about 60 days after MicroPulse laser was administered. And here's an example of him using MicroPulse laser as an adjunctive treatment following intravitreal triamcinolone. This patient, who's 4 months out from the last injection of triamcinolone, still had persistent subretinal and intraretinal fluid. MicroPulse laser was administered, and here you can see almost half a year after the injection, there's no residual subretinal fluid and a marked reduction in the intraretinal fluid, with improvement in the vision from 20/80 to 20/30. These treatment effects are often quite durable. Having a long duration here is demonstrated in this patient 19 months after a MicroPulse treatment with resolution of the central thickening. So what to consider when you first want to start using this treatment? I think one of the best patients to start this therapy with is a patient with extrafoveal clinically significant edema. Here, just as I showed, you can demonstrate a benefit without ever having the fovea involved. Also, it's sometimes a little less advantageous to start something more aggressive like an intravitreal injection when patients don't have foveal involvement because they don't want to go through that injection and the risks of injection when they don't typically notice much problem with their eyes. It's also very valuable for people who refuse injections, as the patient I just showed a few moments ago. It can be used adjunctively to people who are not responsive to anti-VEGF, but in my experience, it's mostly been with people who have milder edema, not unresponsive to anti-VEGF, but before I would use anti-VEGF therapy. You don't want laser scars in and around the fovea, and that's the beauty of the MicroPulse because it can be safely used and repeated in the parafoveal area. What to expect with this treatment? Well, you don't really see any tissue change when giving the laser treatment. That's one thing that's unusual and you have to get used to and try to figure out where you are during the therapy. It's best to treat extensively, though, light treatments that aren't going to cause any change, but fairly high density application seems to work better than applying small PRP or grid kind of spots that we're used to. So you have to treat much more tightly to get the best benefit than my experience and what many people are now coming to that conclusion now. It does seem to be safe to repeat, and patients certainly feel a lot better with this treatment than most others because it's pretty painless. Some patients report a subjective improvement, but not all right after the therapy. But I do think it's better in milder cases, earlier cases. You can demonstrate the benefit easier and don't get confounded by the anti-VEGF treatments. So in summary, we have histopathology, which shows no damage or very minimal damage, especially at the doses we use in patients. We therefore think that MicroPulse laser is a much safer technology than typical laser, which leaves a visible spot and histologic burn. We've also had many case series now, as well as randomized trials of late, showing a statistically significant improvement following MicroPulse laser for DME. Many are now using it in conjunction with anti-VEGF therapy. Although the data is still a bit immature in this regard, it's still very intriguing. I think MicroPulse laser will expand the way laser is used, as it is such a safe treatment, and hopefully will be proven to be effective in many patients, not just diabetics, but in other conditions such as central serous and vein occlusion. Thank you very much for your attention. I'd like to turn the podium over to Alan Ho, who will be going to the next session.
I'd like to thank everyone this evening. I'd also like to thank my colleagues and friends. I've got a question that I'll direct this to Larry Morse. In the sub-threshold continuous wave laser the same as MicroPulse laser? In other words, what's the difference?
So there is a difference between the two. So we've gone through an era where we've taken most of our continuous wave lasers and tried to turn them down to a point where you visibly can't see a laser burn. When we did animal studies, it turned out that even though we could not initially see laser burns with continuous wave, if we did histology, within about 2 to 4 weeks later, not only could we visibly see them on animals before we enucleated, but histologically, there was definitely evidence in these animals that we initially could not see burns in, that they had structural damage that was evident histologically. So burns may initially appear invisible, but at the continuous wave treatments, we can't turn the duty cycle down low enough that we can avoid thermal damage. So MicroPulse does that for you, and histologically at the 5% duty cycle level, at least we could see very little, if any, irritation of the RPE at all.
And just to follow that, so it's different than low energy subthreshold continuous wave, but for our viewers, how does it work? What do you think are the biological mechanisms of the laser tissue interaction?
So that isn't still real clear right now. All I can say is that we do have evidence that you can upregulate certain biological protein reactions, probably as some sort of stress response to the delivery of light in this low intensity but high density sort of pattern. So it does create an anti-VEGF effect by doing that, because you can actually see those markers that are upregulated following that treatment. How the light is doing that is still, I think, not clearly defined.
Okay, good answer. And similarly, I would say we still really don't know how traditional thermal laser photocoagulation works, other than we do know that it burns tissue, and that over time some of those diabetic maculas show expanding atrophic scars. Bob Avery, how do you keep track of where you've treated, since there's no ophthalmoscopically visible endpoint? How do you keep track?
Well, it is something you have to get used to after years of following a thermal burn. But you just look at a landmark, for instance, a bifurcation of a vessel or something of that sort, and keep if you're using the grid machine, the one that will do a 7x7 grid, it's easier because you can keep the edge of the grid, say, adjacent to that landmark and then move accordingly. When you're not using the grid, it's a little trickier, but you can just go in a linear fashion back and forth and try to do what the grid does. But you do have to try to keep a landmark in mind and realize where you are. Although with this treatment, if you accidentally over-treat an area you've just treated, we don't know if that really causes any damage or not. I'm sure that happens to all of us not using the grid, but it doesn't seem to cause a problem.
And that's a really important point that Bob Avery just mentioned, is that you can retreat and not have a problem with a safety issue. In fact, sometimes you need to retreat over the same areas to titrate a tissue response. I've got a question that I'll give to Elias. Do you vary parameters with media such as cataract? And can you go above 400 milliwatts, for example, if there's a dense cataract or not enough response?
Yeah, well, the problem is you can't really measure response. So the endpoint is very different here. There is no endpoint. So generally, you're looking for a therapeutic response over time. And so if I have an individual who I've treated, and if I have a dense cataract, that patient, even if they're darkly pigmented, they're going to get maximal therapy, which to me is 400 milliwatts with a 5% duty cycle. So ultimately, they're going to be seen, at 6 weeks and then at 3 months. If you're not seeing a tissue response, you're going to have to do something different. So you can increase your power setting, or you're going to go to alternative therapy. But the reality is you are limited in knowing how much energy you are applying to the retinal pigment epithelium. So that is difficult. And, I think the other side, the converse of that statement is, you have to be aware of different pigmentation of the retina. So if you have a lightly pigmented individual, I'm more than, enthusiastic about going to 400 milliwatts power with a 5% duty cycle. But if I have a more darkly pigmented patient, I'm going to be probably starting at, 280, 300, 320 milliwatts with a 5% duty cycle. So you have to look at both sides of the equation to really come up with, the right dosimetry. But cataract is difficult, and you're going to have to really see a therapeutic response over time and titrate that way, as opposed to titrate, at the time that you're doing the procedure.
Right, and to say it another way, MicroPulse laser, there's no visible tissue response. So this is invisible to the treater. And to you, Elias, a question from Brazil. Do you apply the laser directly to the foveal area?
The short answer is yes. And so, I've been doing this therapy now for a few years. Treat right through the fovea. If there's edema, if there's retinal thickening in the center of the fovea, we do the treatment. We do the standard, parameters, less than 400 milliwatts, 5% duty cycle. That duty cycle is very important. Don't go above 5%. I've yet to see a foveal burn or any change within the center of the macula or decline in vision. But, just treat eyes that have retinal edema and don't treat eyes that have normal foveas. That's been our experience, in maculas that are thickened throughout the fovea.
Great response. Another question from local in Pennsylvania. I'll give this one to Bob Avery. Do you still use conventional grid laser for extrafoveal macular edema, or has that been abandoned in favor of MicroPulse laser? Bob, you want to take that one?
Yes, I still use the conventional only in a circinate lipid ring surrounding some juicy microaneurysms that, just because of my stubborn nature, I think respond to ablation of the microaneurysms, not based on the trials that show that focal versus diffuse ends up having the same effect. I just feel stubbornly that if I can ablate those microaneurysms in the middle of a circinate lipid ring, that helps. On the other hand, that's quite a small subset of patients, and everyone else with extrafoveal threatening edema, I do MicroPulse laser on because I think it causes no damage, and I think it's long-term better for the patient. But I still will occasionally go to conventional laser, and having the yellow laser is actually nice because it has better absorption in the microaneurysm. So I use the same machine, but I can't resist picking off a few microaneurysms when you're in the center of a sursonate ring, unfortunately.
Larry, Bob can't help himself. Can you help yourself, or do you do MicroPulse ExtraFoveal still?
So I do just what Bob mentioned. I think the first anti-VEGF treatment that we had was thermal laser. So I do use it for for extrafoveal, well-described lesions, just as Bob carefully defined, and it does have a durable effect. I do keep in mind, though, that laser burns do expand, and so people have to remember that that things will get bigger than what they appear initially. So when you're thermally burning, you got to be careful.
I would agree with that. I am definitely scarred by the scars that have expanded over my practice of over a decade and a half. And but I like Bob and Larry, and perhaps Elias, I still do some thermal laser, but I limit it and do significant micropulse laser in those extramacular areas also. And it takes time for the tissue to respond, and you have to retreat it. I have a question from another listener. Are you concerned that you're undertreating with MicroPulse and then waiting a long time, many months for response? Finding that you have no or suboptimal response, are you losing ground because you have to wait so long for this response?
So that
I'll take that.
Or Bob?
Well, I would just throw out that that's why I first started using the treatment for extrafoveal patients, to make sure I was getting the kind of response that I was hoping to get. And after that mental check that, yes, I can get this to resolve, it does work, I convinced myself with patients where I wouldn't put anyone at risk, then I'm very comfortable now using it in people with central edema, and that's why I say to start that way. But it is true that this is not as fast as the anti-VEGFs, and so if you're really concerned in a patient, you can, do both, a combination treatment. But I actually think that most diabetics, when they first develop central edema, still maintain pretty good vision that first time through, and you'll see a lot of the studies allow a certain amount of edema, for instance, protocol T, before they treat. It's not like the AMD studies where you had to have the foveal bone dry before you gave up treatment. So it's not clear that having a little bit of edema is deleterious long term, and so I'm more willing in diabetic macular edema to tolerate a little fluid versus other conditions like AMD. Hence, I'm not as concerned. But it's a good point. If you don't get much of a reaction, then it may make sense to shift straight to the anti-VEGF.
Very well.
This is Larry. I still, although it works by itself, if things haven't improved within about a 3-month period of time, I'm doing anti-VEGF therapy in concert with this. So I don't think we need to wait excessively long for this to work. I do think it has a synergistic effect, and I wouldn't sit on this for 6 months and waiting. I don't think that does the patient any good.
I agree with that too.
I agree with that as well. We have a few questions on whether or not this is appropriate technology, MicroPulse, for different wavelengths. And the answer is yes, you can use it with your green, you can use it with your longer wavelength MicroPulse capable laser boxes. So I'll just take that one. And then we have a few minutes left. Let me just throw this out to the group. Do you use MicroPulse laser for any other macular edema conditions, and what have you found? Elias, you want to start us?
Yes, sure. So I've tried it for central serous retinopathy, and I'd say mixed results. I still think that with chronic central serous, low fluence PDT is probably the best way to go. But what we're finding that's very interesting, and I don't have an explanation for it, is optic nerve pits. And this is not treating the optic nerve directly, but this is treating the retinal pigment epithelium surrounding the optic nerve. And we now have a series of 3 cases that had prior vitrectomy, membrane peeling gas, done by several retina surgeons, and they had failure of their optic pit to close, and subsequently did micropulsing surrounding the nerve, large grid pattern in the area where you saw this neurosensory detachment, and the 3 of them have done very well. So, we're finding it useful there. And then also, of course, branch retinal vein occlusion. There clearly seems to be a role in branch retinal vein occlusion. And finally, radiation retinopathy. We do see an effect with radiation retinopathy in patients who've been treated with either corticosteroids or anti-VEGF and, subsequently failed those therapies. But MicroPulse seems to have a role there. However, it needs to be repeated. It's not one of these treatments where, you treat them and then you say goodbye for a year or 2. They do need to be followed closely, and they often need retreatment every 4 to 6 months with micropulsing.
Larry or Bob, any want to chime in on other conditions in your experience?
I'll chime in. There have been some reports on using this in juxtafoveal telangiectasia. I personally have not had any success with that, but there are reports of people having pretty good success with that. And then there's another very interesting paper by Jeff Luttrell, who actually, in patients who have become resistant to anti-VEGF, it's a small percentage, but in those resistant patients, there is a series that were reported to gain resensitivity to anti-VEGF therapy following MicroPulse. So there's a couple unusual twists that are being presented that I think are worth thinking about and trying out in your practice.
I would also say that I really like it for central serous as a first line over either conventional continuous wave or PDT. I agree with Elias that PDT is more reliable or consistent, but a much significant increase in cost and hassle of just delivery in the office. And the central serous cases, I think, respond very well if they have defined areas of leakage, not even a specific smokestack kind of leak, but more diffuse leakage. You just treat those areas, and I've had very good response in central serous. But I've read the paper that's coming out in IOVS this year, or maybe it's out, with 10 patients treated with the juxtafoveal with the improved visual acuity. I think about 2 lines of improvement. So I'm just starting to see if I get the same results in those cases, because there's very little else we have to offer for them right now.
Well, you've heard from some of the experts regarding a different way to think about using laser. MicroPulse laser is exceedingly safe. You can retreat the macula. We're talking about low intensity, MicroPulse intensity, and very, very highly densely placed spots. The tissue response is not rapid like anti-VEGF, so you have to be patient. You can treat through the fovea. I still get nervous when I do that, so I'll always test outside the fovea, but you can retreat through the fovea, and when done correctly, this is a very safe way to reduce macular edema, and I would say in a variety of diseases. You have to be patient, and it doesn't always work. So you still need to follow these patients. And I'd just like to thank everyone for taking the time this evening to join us. Very appreciative for Iridex and Bryn Mawr Communications for putting this together. Thank you very much, everybody, and good night.